For decades, the fight against pancreatic cancer felt like a battle fought with a well-worn, outdated playbook. The strategies were limited, the outcomes often grim, and the sense of hope was rationed. But I'm here today to tell you that we are turning the page. We are leaving that old playbook behind, not with incremental changes, but with a fundamental rewriting of the rules of engagement. The landscape of pancreatic cancer treatment is not just evolving, it is undergoing a seismic shift, driven by scientific innovation and a relentless commitment to progress. The research isn't just happening in a lab anymore. It's delivering tangible, powerful new tools directly to our patients, right now. This new era of progress begins with refining our most established tools, surgery and radiation. For years, the major pancreatic surgery, the Whipple procedure, was a formidable undertaking with a long and difficult recovery. Today, we are witnessing a revolution in surgical precision. The increasing use of minimally invasive and robotic-assisted surgery is transforming this experience. These advanced techniques allow surgeons to operate with enhanced magnification, dexterity, and control, leading to smaller incisions, less blood loss, and significantly faster recovery times for patients. This means we can get patients back on their feet and, crucially, onto the next phase of their treatment more quickly and in better condition. Alongside surgical advances, radiation therapy has become dramatically more sophisticated and targeted. We've moved far beyond the days of broad-field radiation that damaged healthy tissue indiscriminately. The advent of stereotactic body radiation therapy, or SBRT, represents a paradigm shift. SBRT allows us to deliver highly focused, potent doses of radiation directly to the tumor with millimeter accuracy, often over just a few sessions. This enhanced precision not only improves quality of life, but also makes radiation a more powerful and viable option for a wider range of patients. Chemotherapy, long a cornerstone of treatment, has also undergone a strategic overhaul. The narrative is no longer just about enduring treatment. It's about deploying smarter, more effective systemic weapons against the cancer. We now have far more potent combination chemotherapy regimens, like FOLFIRINOX and gemcitabine with nab-paclitaxel, that have demonstrated a superior ability to shrink tumors and control the disease compared to older, single-agent therapies. These powerful combinations are hitting the cancer harder and more effectively than ever before. Even more transformative is our strategic thinking about asterisk. When asterisk we use chemotherapy. Historically, surgery came first, followed by chemotherapy to clean up any remaining cells. We've flipped that model on its head. The strategic shift towards neoadjuvant therapy, giving these powerful chemotherapy combinations asterisk before asterisk surgery, is a game changer. This approach accomplishes several critical goals. It attacks microscopic cancer cells that may have already spread. It shrinks the primary tumor to make surgery safer and more successful, and it serves as a real-time test to see if the cancer is responsive to the drugs. This smarter sequencing significantly increases the likelihood of a successful surgery with clean margins, which remains one of the most critical factors for long-term survival. We are no longer just treating the cancer, we are strategically outmaneuvering it. But the most profound revolution, the area generating the most confident excitement, is the dawn of personalized medicine. This is where we move from a one-size-fits-all approach to a strategy tailored to the unique genetic fingerprint of an individual's tumor. The foundational principle of this new era is the mandate of molecular profiling. For any patient diagnosed with pancreatic cancer today, testing the tumor's DNA and RNA for specific biomarkers is no longer an optional extra. It is an absolute, non-negotiable standard of care. We must understand the enemy's genetic blueprint to select the most effective weapons against it. Without this information, we are fighting blind. This molecular data unlocks the power of targeted therapies. For patients whose tumors harbor specific genetic mutations, we can now deploy drugs designed to exploit those exact vulnerabilities. For instance, for the 5 to 7% of patients with mutations in the BRCA1 or BRCA2 genes, a family of drugs called PARP inhibitors has proven to be a breakthrough. These oral medications can dramatically extend the period of disease control, turning a relentless cancer into a manageable chronic condition for a subset of patients. Similarly, we are identifying other rare but actionable mutations, like NTRK fusions, for which highly effective targeted drugs exist. This is precision oncology, in action, matching the right drug to the right patient based on their tumor's specific biology. Within this personalized revolution, immunotherapy is finally finding its footing in pancreatic cancer. While the broad success seen in other cancers has been more elusive, we have identified a specific niche where it can be profoundly effective. For the small percentage of patients whose tumors are classified as MSI high, a biomarker indicating a high number of genetic mutations checkpoint inhibitor, immunotherapies can unleash the patient's own immune system to attack the cancer with remarkable and sometimes durable results. The key was in identifying the right biomarker. This success provides a critical foothold and a roadmap for future research, as we work tirelessly to understand how to make more pancreatic cancers responsive to these powerful immune-based treatments. Fueling this entire forward march is the engine of progress: clinical trials. It is essential that we reframe our understanding of what a clinical trial represents. These trials are not a last resort or an act of desperation. They are a primary pathway to accessing the next generation of therapies today. They are the front line where the battle plans of tomorrow are being tested and validated. Participating in a clinical trial offers patients the opportunity to receive state-of-the-art treatments that could become the standard of care in the years to come. The avenues being explored in today's trials are incredibly exciting and diverse. We are investigating personalized cancer vaccines, created from a patient's own tumor, designed to train their immune system to recognize and destroy cancer cells. We're developing novel drug delivery methods that can sneak chemotherapy past the tumor's defenses. And we are pioneering therapies that target the dense, fibrous tissue surrounding the tumor, the stroma, which acts as a protective shield. By breaking down this shield, we can allow chemotherapy and immunotherapy to more effectively penetrate and kill the cancer cells within. Each trial is a vital step forward, a beacon of hope, lighting the way to better treatments. Ultimately, the future of pancreatic cancer care, a future that is already arriving, is one of integrated, multidisciplinary collaboration. The era of siloed treatments is over. The new standard is a seamless, dynamic combination of these modalities, orchestrated by a team of experts and guided by the unique biology of each patient's tumor. The central command for this new battle plan is the multidisciplinary tumor board, where surgeons, medical oncologists, radiation oncologists, geneticists, and pathologists come together to analyze a patient's case from every angle. It is here that a truly personalized treatment plan is forged, one that strategically sequences surgery, radiation, chemotherapy, and targeted therapies to achieve the best possible outcome. This integrated, personalized approach is how we are turning the tide. It is how we are delivering not just new treatments, but new hope.